Hello, sweet friends. This is our make-up laboratory evaluation of plasma and serum proteins lecture, and I'm giving you a condensed version of this because a lot of these major concepts we've already covered, and it just sort of touches on some big differentials and putting things together. So it's a fairly light lecture to begin with, and I think that we can do this in a reasonable amount of time. That way you don't have to sit here worshiping this lecture for long periods of time. All right, so without further ado, here we go with some introductory type stuff. So as we know, proteins have many functions. They're involved in nutrition and enzymes and buffers and on and on and on. So there's lots of them, and they are present in our plasma as solutes. Most of these proteins are synthesized by the liver, the overwhelming majority of them. And you've made friends with the liver with Dr. Thrall, and you've learned about the fact that albumin will decrease in liver disease, and our coagulation factors won't be made properly when there's liver failure going on. So it's an important concept to understand that the liver, in addition to all its other major functions, also makes these proteins. But the other piece to this is to remember that some of these proteins are also synthesized by the immune system. And these are proteins like our cytokines and our immunoglobulins. And these are upregulated in our massive inflammatory responses. So we can be in complete liver failure and still have an increase in that fraction of proteins that are being made by the immune system. And it's a fairly important concept to wrap your head around, especially when we start talking about what globulins are. So how do we measure protein? We've already talked about the refractometer and measuring the total protein. And this particular measurement is usually reported out on the CBC, because part of the CBC we measure a PCV, and right hand in hand with that little hematocrit tube that we did at the first lab, we get a total protein measurement. As you know, this is an estimate, and our good old friend Chuggle will interfere with this. So when you see this total protein varying or falsely increased, you want to be looking for those other things. So how do we know that that protein might be falsely increased? Well, we also measure the total protein on the chemistry profile. And this is a chemical reaction, and 99% of the time, it's right on point. Every once in a while there will be a measurement that comes out of this that is incorrect, and then it gets published in our clinical pathology journal and discussed at conferences. So if you see a discrepancy between the total protein on the CBC and the total protein on the chemistry panel, first thing, just assume the refractometer is the one that's wrong and start looking for things like cholesterol and hemolysis and lipemia. All are things that are involved in Chuggle. The other thing our chemistry analyzer measures is albumin. So this is an exact reaction again, and we get an exact number for this. So an albumin is a massive protein, and it's within our plasma. It constitutes of somewhere between 30 and 60% of our plasma proteins at any given time. So it's by far the most numerous protein that we have floating around there, which is why we pay so much attention to it. It has other important factors that we'll talk about when we get more into albumin. But when we're looking at the total protein, we have that thing where we precipitated all the proteins and we've looked at that. We've measured an exact measurement of albumin, and what we have left over, the difference between that giant protein fraction and albumin, is what we label the globulin fraction. Okay, it's literally a mathematical equation that you either A, calculate yourself, or B, the computer does the math for you and prints it out for you. The globulin fraction is not specifically measured, it is calculated. And it's a very complicated equation, as we can see here. It's total protein minus the albumin equals the globulin. And it's something to keep in mind, in particular when you're out in practice. Not every machine will report out the globulin fraction. They may just give you a total protein and an albumin, and you need to figure out what the globulins are doing. Remember that The globulins are not just immunoglobulins. So there's a whole semantics thing that gets really confusing. They call it the globulin fraction. Immunoglobulins are one part of that fraction, but it also includes all our hormones and our enzymes and our cytokines and all these other proteins that are suspended in the blood. So it's a really large heterogeneous group. And as I have down here, it's all the proteins except albumin. Okay, so it's everybody else. So don't get too caught up in the semantics. It's really easy, especially when we start talking about differentials for increases in globulin fractions. It does not equal immunoglobulins. Immunoglobulins are a part of that fraction, but it is not all of that fraction. All right. So next up, this is an important concept and a key concept, and I've already touched on it a little bit, but the total protein, our total protein is made up of two fractions, okay? So it's the albumin component and then everybody else, the globulin component. And both of those, when we add them together, equal the total protein. It's important because we can see some changes in albumin and we can see some changes in globulins. And sometimes, for example, like the globulins may increase in inflammation and the albumin might decrease in inflammation, and your total protein will be perfectly normal because they're kind of canceling each other out. So you do need to look at all three parts of this compartment when you're going through your diagnostics. So before we get too far, and since I've touched on inflammation, I'm going to talk to you very briefly about acute phase proteins. And there's two that we're going to talk about, albumin and fibrinogen. And what is an acute phase protein? It is a protein that increases or decreases in the inflammation and inflammatory response. It's a fairly hot topic in the world of clinical pathology and biomarker research, like looking for these markers of inflammation. And there's tons of them. There are just tons of them. So the proteins that increase, that go up during an inflammatory response, they are considered positive acute phase proteins. Okay, they're increasing, they're positive acute phase proteins. Proteins that decrease during the inflammatory response are called negative acute phase proteins. So the two examples that I want you to know, because this is important and it's common terminology, are albumin and fibrinogen. And albumin, the number one differential for a decreased albumin, and what I want you to twitch every time you see it being decreased is this inflammatory? Is this inflammatory? Okay, because it is a negative acute phase protein. If there's an inflammatory response, what happens in the liver is the liver needs to focus on making all these crazy proteins that are involved in inflammation. You remember learning them in general pathology. It was like 10,000 cytokines and 10,000 hormones. Well, the liver, which usually makes albumin, goes, hang in there, albumin. Give me just a minute. I'm going to focus on getting these inflammatory proteins up and going. So the albumin kind of just drops off. And it's usually a mild change, maybe even moving into the moderate range. So it's usually not too much of a change. It's just a slight decrease. But yes, negative acute phase protein because it decreases in the inflammatory response. Fibrinogen, and we've talked about this in the concept of the CBC in large animals. We use it in particular, and Dr. Iverchuk will get you all up to speed on what fibrinogen is and what fibrinogen does. Fibrinogen is a positive acute phase protein. Now, where have we seen fibrinogen before? Remember, and I'm taking you back here a little bit to our coagulation lecture. When we talk about that coagulation cascade, that intrinsic and extrinsic pathway that comes down and ultimately converts fibrinogen into fibrin and clots are formed, we spent a lot of time talking about this response with bleeds, and I had mentioned at that time that as an FYI, that this also occurs with inflammation, and that inflammatory pathway is set off by that whole intrinsic pathway. That's what factor 12 is a big part of, responding to inflammation. And 12 goes to 11, which goes to 9, which goes to 8, and then all the way down the line to start making fibrin. And this is the fibrin you get in things like fibrinous pleuritis, so your inflammatory diseases where fibrin's being laid down. And part of increasing this is your liver will start making more fibrinogen. And we do measure fibrinogen independently. There is a section of Dr. Thrall's textbook on fibrinogen that talks about the heat precipitation method. It's fairly commonly used and pretty easy, and it gives you an idea of whether or not that fibrinogen is being increased within that fraction. And we'll talk about that again a little bit later into this lecture. So, protein abnormalities. The really good news is that we're talking about albumin and we're talking about globulin. So there isn't a huge long list of analytes going on here. And we're going to start off with our albumin. Take it, hang on. We're going to start off with albumin and globulin and looking at them together because we've already talked about them moving together. So when they increase together or decrease together, we put a word in front of it, and that word is pan. So pan-hyperproteinemia or pan-hypoproteinemia. They're both going up together or they're both going down together. The really good news is we've already learned we've already learned our differentials for both of these. So pan-hyperproteinemia, when we have them going up in the same direction together, there is one differential, and that differential is dehydration. Okay. It also happens to be the same differential for an increased albumin. Sometimes a patient can have an increased albumin and not have an increased globulin, so you have to be careful with discerning this, but if you see them both going up together, it's dehydration. And we know that you know this because there was a question on the last exam talking about a patient that had an increased PCV. It was like 68% and an increased total protein. It was like 9.5. And you guys all rocked it out and said, hey, this is dehydration. Well, congratulations, you guys, you have mastered this part already. So pan-hyperproteinemia, that's the medical word, descriptive word, dehydration. On the other end of that, pan-hypoproteinemia, we have two differentials for that. So this is when we are losing albumin and globulin together. And you've already made friends with this. You've made friends with this in when we were talking about anemias. So hemorrhage, that total protein decreases. And it's because when we're bleeding out our vasculature, like the example I give where I'm in a zombie film and a zombie pulls off my arm and I'm hemorrhaging all over the place. We're losing both albumin, globulin, all those proteins, all that serum and plasma, as well as our red blood cells. So that whole compartment goes out. The other time we lose it, and you guys rocked it out with this in case-based, is our protein-losing enteropathies. Okay, so when our protein-losing enteropathies are going on, we're not able to absorb proteins, and we also have all our proteins leaking out into the gut. So there's our two differentials. So only when they're both going up together, there's only one differential, and that's dehydration. When they're both going down together, I want you to be thinking, is it hemorrhage? Is it protein-losing enteropathy? And how do we figure that out? Well, we're going to be looking at our PCVs. We're going to be looking at our clinical presentation and all these other things that we put together within the case. A lot of times with proteins, it's supporting evidence for other stuff that's going on. So how about albumin? One of my favorite proteins. So we can have changes in albumin. They go up and they go down. And the first one that we talked about is hypoalbuminemia, all right? So decreases in albumin. Albumin is decreasing. And I've already jumped up and down about this, but I want you to be thinking anytime you see a decreased albumin, is this inflammation? Is it inflammation? Okay. I want you to be thinking, what's going on here? Is there an inflammatory leukogram? Is there anything else here that looks like inflammation? This is your number one differential. Inflammation is really common in our patients that come in and get sick. Like the immune system is a huge part of life, okay? So inflammation. Then get your fingers out and start building up your other differential list because there's 5 big ones. We've talked about liver failure. So how do we tell that albumin is decreased in liver failure? Well, we're probably going to see things like increased liver enzymes, right? And we're probably going to see things like decreases in other things the liver enzyme activity. Here we go. And we're going to probably see decreases in other things the liver makes, the synthetic proteins. Okay, so like albumin and cholesterol and glucose and all those other things. And we're probably going to see increased bile acids or increased ammonia. Okay, so that sort of thing this is supporting evidence for liver failure. So you've got a low albumin, you go, what could it be? First thing I want you to do, inflammation, inflammation, inflammation. Is it inflammation? Then start building other things. How's the liver doing? Is this something that the albumin is being lost with the globulin? So here, when we have our blood loss, we've already talked about this. Whoops, didn't mean to do that. Hang on. Sorry about that. I thought I had my highlighter on. We've already talked about blood loss with hemorrhage, and we've already talked about intestinal loss with protein-losing enteropathy. So these are going to be on your list if the globulin is down as well. So, and those are going to be at the top of the list there. So, okay, we've already sort of talked about that. So inflammation, liver. The next thing is it a protein-losing nephropathy? So sure, have we talked about this? Yeah, we talked about it in our urinary lecture. And in protein-losing nephropathy, these glomerulonephropathies, where they're leaking protein, remember that albumin constitutes almost 50% of the protein fraction within the blood, and it's a small protein, and so it leaks very readily out through those glomeruli. You get massive proteinuria, and your albumin in your peripheral blood starts to decrease. So that's the next thing. You're looking at albumin, you're going, could this be kidney? Could this be renal disease? And you're going to need a urinalysis to really sort that particular bit out. The third thing is there any third space dilution going on here? So this is like an effusion or a vasculitis, okay? So sometimes if we're in liver failure, for example, we're going to have an effusion in our abdomen, and it'll be a high protein effusion. And something that will happen is that as that effusion develops, albumin's going to distribute itself between that plasma fraction and that effusion. Okay, and it will look decreased in the plasma. In the whole body, it's the same amount of albumin that's present, but it's decreased out there. Vasculitis, when you get leaky vessels, albumin is like this tiny protein. It's like, I'm out. So it heads out and will actually pull water and cause some edema with it as well. So here we go. Inflammation, liver failure. Are we failing in the liver? Are we losing it out the kidney? Are we losing it out the gut? Are we bleeding, right? Is there a third space dilution going on? This last one down here, skin disease and burns, is something to keep on your list, but I will tell you in my time in clinical practice and even in the emergency clinic, I saw this very, very rarely. And it's going to be something that you're going to associate like, hey, albumin will decrease when we start seeing stuff like this, because with really bad burns, and I don't know if any of you have ever had one, but your body just like oozes all this serum. If they're bad enough and severe enough, you're going to start seeing decreases in your albumin because it's going to be exiting the body this way. But overall, like when we're looking at this list, I want you to be going, is it inflammation? Inflammation. Is it inflammation? Okay, have I emphasized that enough? Is it liver failure? Are we losing it out the gut? Are we losing it out the urine? Are we bleeding? Or is there an effusion going on? Those are our big ones for albumin. And like I said, with most of these things, we're going to be looking at other factors, and albumin becomes a supporting factor in all of this. So how about increased albumin? Well, I have really great news for you. There's only one differential, and that is dehydration. Oh, and that's fabulous. I keep doing this. It's dehydration, okay? There's one differential, dehydration, dehydration, dehydration. And you know what? Hey, wait a minute. Have I seen this before in this lecture? Oh, yeah. Way back at panhyperproteinemia. Remember that? Albumin's up. Oh. Oh, so increased albumin means the patient's dehydrated. Absolutely. That's what we're going for here. So this usually occurs with the globulin fraction, okay? It usually occurs with globulins, but sometimes we will only see albumin increase. The bottom line is, and this is the thing you really need to know, okay? The bottom line is if the albumin is increased, okay, it is dehydration regardless of what the globulins are doing. All right, if the albumin's increased, it's dehydration. Wham, bam, thank you, ma'am, and we are that. So globulins. Globulins are fun too. We can see changes in globulins, and it's relatively unusual to see a hypoglobulinemia, okay? And when we see hypoglobulinemia, most commonly we're losing it. And we've already talked about it in the context of hemorrhage and protein-losing enteropathies, okay? We've already talked about it in this context and in this context. It's going to be lost with albumin, so you will have pan-hypoglobulinemia in these. We use this once in a while in our babies, our neonates, our foals, and our puppies and our kittens to see if they have gotten colostrum, especially if they're sick in their infancy. So one of the things we look for is there failure of passive transfer in neonates. So globulins are a major part of that colostrum. It should actually be normal to increase in our neonate patients. So this is one of the big things that we look for. The other thing on this other side is decreased production. Once in a while, we get a patient that has severe combined immunodeficiency syndrome or SCIDS. These are patients that don't develop functioning lymphocytes, and they aren't able to make antibodies, and they aren't able to make inflammatory proteins. Usually these patients get profoundly sick in their infancy or early childhood, and by the time they're like 6 months old, they're usually dead. It's super, super sick patients. So the big ones that I want you to remember, like if you take nothing else out of this lecture, okay, remember that panhypoproteinemia that goes on with these guys, hemorrhage and protein-losing enteropathy, and just keep it in the back of your head, particularly those of you who are interested in equine medicine, is that we will sometimes see decreased globulins in failure of passive transfer. So the really fun one is changes in globulin associated with hyperglobulinemia. And so these are increases in globulins. We've already talked about they will sometimes increase with dehydration. We see that with albumin. It's a relative increase, so we're not actually making more proteins in the globulin fraction. We're losing water. The two big differentials that I want you to have locked into your head is this inflammation or is it neoplasia when those globulins are going up? So what's more common? Well, clearly inflammation is more common. We've talked about it already. So wait a minute, have we talked about inflammation? We have. So what do we see in inflammation? Remember, you're going to see a decreased albumin. Your albumin will be decreased, and you may have an increased globulin. Ha ha. Okay, so your albumin fraction may be decreasing, your globulin fraction may be increasing. So when do we see this? We commonly see this in infectious diseases and non-infectious diseases that are present on more of a longer term basis. They tend to be smoldering diseases. So for example, canine ehrlichiosis. We all know Dr. Thrall absolutely loves this disease. She does a ton of research with it, and she's in the Mecca of Ehrlichia down here. One of the things we see very commonly with these patients is an increased globulin. And it can get really tricky, especially if you're worried about this patient potentially having a cancer down here because everyone has Ehrlichia. The other time, anytime you see an increased globulin in a cat, increased globulin plus cat, I want you to be thinking about FIP. All right, it's a classic NAVLE question. Okay, NAVLE, and we're talking about kitty cats here. Okay, so it's obviously important because I love cats, and we know that, right? So you're probably not only going to see it on the NAVLE, but you'll probably see it on an upcoming exam. Increased globulin plus cat, I want you to be thinking about FIP. Okay? Go there first. We do have some non-infectious diseases that stimulate the immune system. Oh, wait for it. Immune system, immune-mediated diseases will do it, and then sometimes we'll see it with necrotic diseases. There are some tumors that you may have that form these huge, like, masses, and they start to abscess in the middle of it and necrose and get really disgusting. So those are the other two times. So increased globulin, inflammation first. Second, is it a neoplasia? Well, the really good news is there's a really short list of neoplasias that cause this, and our neoplasias are B-cell based tumors, okay? So we know that B cells and B-cell lymphomas will do this. So here's our little B cell, like, hi, I'm a B cell, all right? Here's our B cell, and our B cells will differentiate into plasma cells, okay? This is a mature B cell is a plasma cell. And it's an important thing to keep in mind, okay? So plasma cells tend to be a little bit bigger. They've got deeply basophilic cytoplasm. I don't have that many colors in my highlighter here. So we've got that eccentrically placed nucleus, okay? So we've got this whole line of diseases here. B-cell lymphomas will do it. And then plasma cell tumors. The big one we talk about is multiple myeloma. The other one, and don't forget plasma cell tumors, which is the less severe form of plasma cell-based neoplasms. So this picture over here is one of my favorites. It's a cytology from a spleen, and these are all little itty-bitty plasma cells that are in here that are neoplastic. They're like, we're making lots and lots and lots of ourselves. Remember that these guys, their major job is to make antibodies, okay? Antibody, antibody, antibody. And they secrete this in large volumes, and this is what increases our globulin fractions in these patients. So one of the things to keep in mind is that when you have a high globulin fraction, if you don't have something that's obviously pointing you in the direction of inflammation or neoplasia, or you have a patient that could go either way, which happens from time to time, there is another diagnostic option for us. And this is something called protein electrophoresis. And for those of you who have maybe been biology majors or done research, you may have run protein electrophoretograms. It's the same sort of instrumentation. So it's commonly used to separate out serum proteins. And what happens is we have a gel, we have a nice little gel present. Here's our gel, okay, that we make. And it's got a whole bunch of wells at one end. And we drop our serum into these wells, and they move down across the gel. And they will separate out based on their size. So bigger particles, bigger parties move slower. Yes, they do. No, they, what? Okay, so bigger proteins will move more slowly. Okay, so when they're larger, they don't move through this gel as fast. It takes them more time. So smaller proteins will move farther. And the other thing is they're being pulled through this gel based on an electrical current. Okay, and as they're pulled through this gel, our proteins that have a negative charge go the farthest. So one of the things that when you're evaluating things, I want you to know that their movement depends upon the net charge, and it depends upon the size and the shape of the protein. The bigger the protein, the more slowly it moves across the gel. So what we end up getting is we load our serum in here. So this is the well would be down over on this end down here. We load our serum in down here. We apply an electrical current, and very slowly our proteins move across. And over a certain period of time, we stop it, and we take this gel and we stain it, and it goes through a machine that is able to quantify based on how dark these bands are, what proteins are present. So one of the things to remember is if this is a serum sample, I told you that albumin is the biggest fraction in there. And we know that albumin is a tiny protein, and we know that it carries a really strong negative charge. So this peak down here, it moves the farthest. This is our albumin, this huge peak. So, and it constitutes almost 50% of it. So here's our albumin right here up in this thing, okay? And then as we go back, all these other proteins that are getting separated out here, 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 and here, these are all within that globulin fraction. So remember that the globulins are really heterogeneous. When we get readouts from this program, we get them in percentages and we get them in absolutes. And I want you to pay attention to the absolutes. Okay, that's the one that's really important. Percentages vary based on your total quantity, but absolutes are going to give you nice numbers. And you will get a reference interval with these in most cases, showing you which ones are actually increased and which ones are actually decreased. And the pattern of increasing and decreasing gives us an idea as to what's going on with our different patients and our globulin fractions. Okay, so when we're looking at our electrophoretograms, as I just mentioned, our albumin is the smallest protein. It has the highest negative charge. It migrates the fastest and furthest. So this biggest piece here on your protein electrophoresis is your albumin. Our globulin fraction, and remember they're a heterogeneous group, do not migrate as far. They're bigger proteins, and they don't have that humongous negative charge that albumin has. And they move across in like different lumps and bumps. And we have categorized the different lumps and bumps by alpha 1, alpha 2, beta, and gamma. And I don't expect you guys to memorize this, but what I do want you to know is that these guys, this fraction here that is in this maroon, the alpha 1, alpha 2, and beta, these guys are mostly synthesized by the liver, okay? And there are a lot of different proteins that are found in that. And this gamma one over here is the one that contains our globulins, okay, the IGs. And this becomes important when we're looking at different patterns that occur with different neoplasms. So when we get results back on these protein electrophoresis, we run them when we have a patient that has remember high globulins, okay? So, and we're trying to figure out what's going on in the globulin fraction. And this is an example of one that looks nice and normal, okay? Our albumin is nice and high up here, as it should be, and then we've got a whole bunch of lumpy bumpies coming back down here. This is what it looks like when you have a normal differentiation. Our big questions when we're asking this is that hyperglobulinemia due to inflammation, or is it due to neoplasia? That's our two questions. We get two very distinct and different patterns depending upon the underlying process. So in inflammation, there's all sorts of proteins being produced. There's globulins being produced, there's cytokines being produced, there's fibrinogen being produced, all these different things that happen. So what we have happen here is we've got our normal is outlined in black here. These red peaks are what's abnormal. So we get multiple peaks here. Multiple peaks here, 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 all throughout this gamma fraction and inflammation, okay? And then those of you who are astute clinical pathology students may have noticed that this albumin fraction is decreasing. Remember, number one differential for a decreased albumin is inflammation, so it's normal to see that response where we're having decreased albumin and an increased globulin, okay? Decreased albumin, increased globulin. Okay. The other part to this is a monoclonal gammopathy. This happens in our neoplasia. First thing to notice, our albumin's nice and normal. Okay, so no inflammation going on, that albumin remains normal. And everything else here, on this little lump, and this one, all looks just fine. And whoa, ho, ho, here we have in this gamma fraction a huge peak. Okay, and this is our plasma cells that are producing large numbers of globulins or parts of globulins. So these are our IGs. So like for example, in a multiple myeloma, one of their favorite things to make is IgM. and they'll sit there and they'll be like IgM, 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 lots and lots and lots of them that are increasing this globulin fraction, and it causes this huge peak that we have over here in this gamma region. So we call that monoclonal because it's one peak, mono, one, clonal, that there's one type, gammopathy. So gammopathy, disease of the gammas, the globulin fraction. And that is a pattern that we see with neoplasia. Polyclonal, inflammation. Inflammation is a cluster. All sorts of things are going down within your system. All sorts of cytokines, all that stuff. It's going to have lots and lots of proteins increased all over the place, and your albumin is going to start to decrease. So polyclonal is a hot mess. Monoclonal, you get this peak, one specific peak. So a quick word on fibrinogen, and we talked about positive and negative acute phase proteins up in the introduction, and I talk about fibrinogen here because it is a positive acute phase protein. But one of the things to remember with fibrinogen is that when we're measuring our total protein, our albumin and our globulin, we measure them in grams per deciliter, grams. Okay, so a full gram per deciliter. Our fibrinogen fraction that we see is measured in milligrams, so it's a much, much smaller portion. Okay, it is in that globulin fat fraction, so it's your total protein, your albumin, and then everything else. It's one of the everything else. For those of you who are ClinPath nerds, it's located in the beta globulin fraction within the protein electrophoretogram. I don't expect you guys to know that, but those of you who are excited about it, there you go. And increases in fibrinogen alone, when it's fibrinogen by itself, usually do not significantly affect the total protein concentration. And that's because it's measured in this smaller amount. It's a little tiny protein in that whole globulin fraction. It's just one little bit of it. So we can have some different things going on that cause decreased levels in fibrinogen. Hypofibrinogenemia, so decreased fibrinogen levels. It's made by the liver, so of course liver failure has to be on our list. And the other time that we've seen this is in DIC, which is in that consumptive phase of coagulopathy. The one that, for the purposes of this lecture, that I really want you to keep in mind that we use fibrinogen for when we're measuring in large animals is looking for inflammation. That's your major differential. It is a positive acute phase protein. So it's a positive protein. It increases, okay? It increases when there's an inflammatory response, positive acute phase protein. You may see it increased in renal disease in cats and cows. It's a thing. Unknown mechanism, no one really knows why. So, but if anything on this slide, I want you to keep in mind that it's a small portion of the whole total protein fraction and that small portion of that whole globulin fraction, and that it's a positive acute phase protein. Those are the two. All right, and that wraps up proteins. So hope you enjoyed it, and we have to take a minute and meet our friends in study time. This is Nala. She's totally adorable. Look at Nala. Oh, these are cute. And Charlie, puss, who's helping study tables and charts here. So there's some cases to practice from, and some additional reading if you're interested. And I hope you guys have a fabulous weekend. All right, take care. Bye.